Thank you. I'd like to thank the International Cardio-Oncology Society for having us this morning and presenting on the Journal Club. And I'd like to thank Stephen for his coordination and just being there whenever we had a question. Thanks, Stephen. So I'd like to start introducing myself. My name is Talal Al-Otaibi. I'm one of the cardiology fellows at Beth Deaconess Medical Center. This is basically our East Campus wing. My special interest is in cardiac MRI, and that's where my personal interest is. And this is the East Campus where we have our cardiac scanner. Today I want to share with you an article that I thought it was interesting for three reasons, basically. One, I thought it addressed a very relevant clinical question in patients that are being treated with Ibrutinib. It has been documented that atrial fibrillation is a common side effect and a notable one, and a challenging one to say at the time. The second reason I chose this, I thought the authors well thought this through and came up with a beautiful design into how they proved the underlying mechanism of atrial fibrillation in this category of patients. And third reason, I thought this is a great example of translation medicine in which they are bridging the lab to the clinical field. So for those three reasons, I thought this article was the article that I wanted to go and present today. I know some of you have reached out to Stephen asking about the article. Unfortunately, my copy was from the Harvard Medical School library, and I was not able to share that with you, but hopefully this will be available for everybody soon to review. So I have no financial or other disclosures pertinent to this talk. And before we start, I just wanted to make sure that we're all on the same page in regards to what we mean by the terms that we have later on. So there are three terms that I'm going to discuss earlier, just to make sure everybody we're on the same page on that before we dive into the paper. So Bruton's tyrosine kinase, we're going to abbreviate it from now on as BTK. It's a cell-mediated signaling mechanism within the cell. Basically, this signals internally to either activate proliferation or release of cytokines through basically a phosphorylation mechanism, but I'm not going to go into that detail. The second term that I wanted to make sure that everybody has relevant in their mind is the C-terminal SRC kinase. So this is an indigenous, this is the kinase that's found within the cell. It is an inhibitor, as in it stops the function or activity of the SFK, which is the SRC family tyrosine kinase. It's like its brake. It stops it from working, and as you could see, it works through phosphorylation of the SFK families. So the SRC family tyrosine kinase has a broad range of activities. It ranges from proliferation, migration, adhesion, inflammation. So it has a long cascade. Many signaling and activities that it does on the cell. So to just recapitulate on this, so we have the more CSK you have that's active, the less function of SFK you have. The less CSK you have, the more SFK function you have. The third thing that I wanted to address and just make sure everybody has this in their mind is the calmodulin-dependent protein kinase. So I'm going to refer to this from on as calcium MK2. So it's involved in many signaling as well. It has been linked to learning and memory, a calcium homeostasis, a calcium reuptake in the cardiomyocyte. But what's relevant to our talk is the last two, is the positive T cell selection and the CD8 T cell activation. In the journal, this journal that I quoted here, they prove that this calcium MK2 activation is a pro-inflammatory, has pro-inflammatory effect that exerts on the heart here. So I need that to be relevant as we talk later on in the talk. So we have, I'm going to mention over here the BTK inhibitors that are currently approved for hematologic malignancies. There are other BTK inhibitors that are used in multiple sclerosis and SLE, but we're not addressing them here. So we have Ibrutinib that we're going to be talking about for this talk. We have Acalbrutinib, which is a second generation BTK inhibitors. It's been approved, I think, in October 2017 for mantle cell lymphoma, and currently is in a phase 3 trial for CLL. And we have Zanbrutinib, which is an oral BTK inhibitor. I think it's used for mantle cell lymphoma as well. All right, so we're gonna start talking about the paper itself. So just to give a perspective of the background, Ibrutinib has really been a game changer since its introduction. It's now the frontline. It's frontline for CLL, and it's been approved for many hematologic malignancies, with great efficacy, as been noted in multiple publications. And as of now, it's a first-line therapy in many malignancies. But with the increased use, a side effect had been noted, and increasingly reported and published, and that's atrial fibrillation. So atrial fibrillation is really a big challenge in these patients. With the effect of Ibrutinib, the patients are at a higher risk of bleeding. And with atrial fibrillation, you're in this, as a clinician, you're in this clinical dilemma. Do I anticoagulate, increase the risk of bleeding, or do I not anticoagulate and take the risk of having a probable embolic stroke? So you really have that dilemma when you treat these patients. And sometimes this might lead to really stopping the drug in total. So this has been a major concern for the clinicians really addressing these issues and dealing with these kind of patients. Unfortunately, there's we don't really understand the mechanism of why atrial fibrillation happens with patients in the Ibrutinib, and that's really has not been fully addressed in previous publications or attempts. So our authors took on this mission, and they went on a mission to really find out what is the underlying mechanism of atrial fibrillation in patients who are receiving Ibrutinib. The way I'll be presenting it today is I will be presenting the findings as a sequential event. So the way I will present it, as they found the first finding led to the second finding, led to the third finding. And my aim of doing so is really trying to give us a perspective of what's going on, and hopefully making it easier for us to understand why they did one step to the next. That's not how they did it when they did their experiments, or how they reported it. But I believe that this will make it easier for us to really understand what's going on. So the first experiment that I will be addressing here is that they wanted to prove that Ibrutinib does cause increase in atrial fibrillation as reported previously. So what they took lab mice, and then they injected them with an intraperitoneal Ibrutinib. They used a daily dose of 25 milligrams per kg per day. And that was given for 4 weeks. The reason they chose this dose is that when they reviewed the literature about the efficacy of Ibrutinib and the cardiac toxicity, this was the most common dose that was used, and that's why they came up with this number. So after 25 days, they took the patients. They took the mice, and they tested for AFib inducibility. Their definition of atrial fibrillation that they considered to be atrial fibrillation was a rapid heart rate, an irregular atrial activity, and a irregular RR interval that lasted more than 1 second. So that was the definition of atrial fibrillation. So when they compared the control group to the mice that received Ibrutinib, they noted a couple of findings that we'll be talking about now. First, they noted that the mice receiving Ibrutinib had a significantly higher percentage of atrial fibrillation inducibility. They found also that the mice who are on Ibrutinib showed left atrial fibrosis, both on the histological histological images. The mice receiving Ibrutinib showed left atrial dilatation compared to the control group. The left ventricular ejection fraction were equal in both groups. Before I move on, I'd like to the authors later on addressed why this happens. So I just want everyone to just pay attention to this, that the LV function and LV are similar between the control and the Bruton group, and the atria showed more dilation in the atria. And the authors addressed why they think this happens, but that's in a later slide. I just just wanted to point your attention to that. They also noted that there is the circulating TNF, alpha, and IL-6 were elevated in patients receiving Ibrutinib, which to me initially was not something I expected. They further tried to address why they thought that the circulating TNF inflammatory markers are elevated. And their theory behind this is the calcium MK2. So as we mentioned earlier in our definitions, that calcium MK2 is a pro-inflammatory signal mediator. So they believed with their findings, and when they took the left atrium of mice receiving Ibrutinib, they found out that they have calcium MK2 were higher in the Ibrutinib compared to the control group. And they hypothesized that's probably why we have higher TNF and IL-6 in mice receiving Ibrutinib. This needs to be further evaluated, but this is, I believe, a really good theory that might be the reason that we have high circulating pro-inflammatory markers.
Talal, this is Dan. I was just wondering on those MRIs. I mean, those are MRIs in mice.
Correct.
So they're tiny. Mm-hmm. So how reliable is tracing the left atrium?
That's a good question. That's a very good question. First, let's start. They scan their mice with a 4.7 Tesla scanner. And if you notice, they included the left atrial appendage, which we don't do in a clinical for our clinical scans in humans. But they did it in both groups, so I think that can be used. The reliability behind that, they did not mention about inter-observer variability, and they did not mention in comparison, but in more detail about it. So I really don't know if they mentioned that in any other article similar to that. But
did they do it in any kind of blinded fashion, or did they know which drug the mice were on?
No, it was blinded. Who was assessing the atrial appendage did not know which group the mice came from.
Okay, thank you.
No problem. So I'll summarize the findings of the previous of our current test. So this is comparing control to a Ibrutinib group. So we noticed that the atrial fibrillation, that we noted more AF inducibility, we noted left atrial dilation, and we noted left atrial fibrosis and increase in inflammatory markers. So now the authors wanted to find the proarrhythmic side effect of Ibrutinib. Is this due to its target effect on the BTK? Or is it an off-target effect? So is this side effect due to its intended function, or is it due to something that it's not intended to do? So that's their first question that they wanted to answer. To answer that question, they induced a mutation in mice that made the PTKA loss of function of the BTK. So that's this group over here. From these mice, they treated a subgroup of those with ibrutinib. Again, the same dose and for the same duration for about 4 weeks. And then they repeated the same test that we had previously. And then they compared it to our previous group that we discussed earlier. So these are patients that do not have function of BTK. And in this group over here that we noted over here, they receive ibrutinib. So the theory behind this is if the atrial fibrillation is due to the function of ibrutinib on inhibiting BTK, the control group should show evidence of atrial fibrillation, which we don't see over here. But when given ibrutinib, that we know there's increase in atrial fibrillation, which would suggest that the atrial fibrillation is really off-target function. So this is not due to the inhibition of BTK that is intended from ibrutinib. So from this experiment, we can conclude that the atrial fibrillation is not due to the ibrutinib's targeted or intended function, which is inhibition of BTK. They also noted that there's fibrosis as well in the ibrutinib-treated patients, and not in the patients that lost the BTK function due to mutation without ibrutinib.
So that pathology is in the atrium of those mice?
There's our left atrial biopsies.
Okay.
Correct. Those are left atrial biopsies. Again, it's the same function, the same as I mentioned earlier. Just to recap, is that the BTK mutated mice that have loss of function did not show atrial fibrillation, but the mice that were received BTK or ibrutinib showed increase in atrial fibrillation and fibrosis. That would make us think that the atrial fibrillation is really an off-target effect. So it's not due to the intended function of ibrutinib. So the next question they wanted to address is, what are the targets that ibrutinib is affecting that causes the atrial fibrillation? So they did a really elegant experiment here, and I'll explain it. It's a little complicated, but I think we can go through it easily. So if you remember earlier that acalabrutinib is a BTK inhibitor that is currently a second generation that is currently not approved for CLL and is on a phase 3 trial currently. So with acalabrutinib, as of now, there has not been any reported atrial fibrillation upon its use. So the authors here did a similar experiment with acalabrutinib. They took mice, they gave them acalabrutinib for 4 weeks, and they did a similar investigation. They did not note any atrial fibrillation inducibility. They did not note fibrosis, and they did not see left atrial dilatation as they saw in the ibrutinib group. So with those category of mice, they took the left atrium and they did something called chemoproteomics, and this really to identify the proteins that are available in the left atrium, and that causes more than 90% inhibition in both groups, in the ibrutinib group and acalabrutinib. From this sequential process, they came up with these proteins. So in acalabrutinib, they found BTK to be inhibiting more than 90% with the function of acalabrutinib, and they found that the RIPK3 also was inhibited more than 90% here, and this is the acalabrutinib group. Whereas in ibrutinib, they had those two kinase, and they had CSK, FYN, and MEK5. So they concluded here that BTK, we did our experiment and we excluded that BTK from our previous experiment is not the inducing factor of atrial fibrillation. And since they assumed, since acalabrutinib group, that the mice did not show AF inducibility, then they excluded RIPK to be the culprit factor here. So they went on a quest of trying to exclude the remaining kinases over here. So the way that they approach this is by this means over here. So commercially available is seracatinib, which is a FYN inhibitor available in the available to use. So they use that as an inhibitor of the FYN kinase, and they also induced a knockout mice with a knockout of the FYN gene, and they also investigated these mice. And finally, to exclude the MEK5, a commercially available drug, which is noted over here, is available that has an inhibitory effect on the MEK5. Again, they used the similar dose and for similar duration on these groups over here. And then they really went and investigated each group to see if for the atrial fibrillation inducibility here. They did not note that in the calbrutinib, but we mentioned that earlier. They did not note that in the FYN knockout gene. And they did note in seracatinib an increase, but this was statistically insignificant. So they assumed that this is not the culprit, specifically since the knockout gene did not show inducibility as well. And they thought this is probably a small side effect from the seracatinib off-target function. And for the MEK5, they also noted that there was no inducibility. So with these experiments that they did, that we can conclude that the FYN and MEK5 and RIPK are not the culprit in inducing atrial fibrillation in Ibrutinib. So we're left with the oh, sorry, I forgot this one. It has been reported that the FYN of the SRC family tyrosine kinase had modulation in the sodium channel in cardiac sodium channels. So they went to investigate, is this atrial fibrillation due to induced by electrical abnormalities through the sodium channels? So they investigated, they monitored the the sodium channels in the control and the Bruton group. And their conclusion is that in both groups, the control and the Ibrutinib, the inactivation and the activation voltage-dependent channels is not different. They're basically the same. So they excluded that the sodium channel effect of the FYN that has been reported is a culprit behind the atrial fibrillation. Okay, this is just to recap what we just mentioned earlier. So now we excluded that we identified that the Ibrutinib is associated with higher atrial fibrillation. We excluded that the BTK is the triggering factor for atrial fibrillation in Ibrutinib. We excluded other kinases as FYN and the MEK5 to be the culprit. So we're left with the CSK now from our investigation. So the CSK assessment of the proarrhythmia happened in the following manner. So a knockout of the CSK from mice was embryologically lethal. So when they knock out the CSK in mice, they found out that the neural tube, there were a lot of neural tube defects, and death was induced within embryonic day 9 and 10. So they went on another classical biologic technique, which is the Lee cross phenomenon, which they induce inhibition of the function based on a trigger. The way they modeled this example is that they modeled the CSK inhibition with the treatment of tamoxifen. So by giving tamoxifen, this is Lee cross technique. So what they did is that by giving tamoxifen, they inhibited the function of CSK. And that's a temporary inhibition as long as tamoxifen is given. So what they did is that they gave tamoxifen, they inhibited the CSK, and they waited for the 28 days, as they did with Ibrutinib. And then they investigated these categories of mice that had CSK inhibited or loss of CSK function. And this category of of mice, they found out that AF inducibility was higher than the control group. They also noted that there is left atrial fibrosis on histological imaging. Circulating TNF and IL-6 were also elevated in mice that had their CSK temporarily lost. So in summary of this experiment, that we know that with mice that lost the CSK function, AF was more likely to be inducible. There were left atrial dilation, left atrial fibrosis, and increased inflammatory markers. So taking all this information together and comparing it to our first experiment where we found Ibrutinib was given, and these findings were similar, that would suggest that the atrial fibrillation inducibility of Ibrutinib is an off-target side effect in which the CSK is the main reason. As of now, I think the CSK is not necessary for the clinical efficacy of Ibrutinib's BTK inhibition. All right, so this is the slide that I found very interesting, and as I elaborated, addressed earlier, that the left atrial dilation was noted in fibrosis in comparison to the left ventricle. So with that, the authors really wanted to know why. So what they did is that in the left atrial and left ventricular sample, they looked for the expression of CSK. So they did that in mice, and they did that in human. And the humans are from 7 patients who underwent mitral valve replacement. They took samples, and they looked for a CSK level on a human heart. In both categories, CSK was more represented in the left atrium compared to the left ventricle in mice, and that finding was similar in humans as well. So that would answer our questions that the left atrial dilation is noted where we have preservation of the left ventricle size and function. And that also tells us that this is probably why we have atrial fibrillation, not ventricular fibrillation. That due to the CSK expression in the atrium, it's more likely to be causing atrial fibrillation than the ventricular fibrillation. So with this finding, the authors went and tried to look for all approved kinase inhibitors that are available. And they wanted to find out from these kinase inhibitors that inhibited the CSK, was atrial fibrillation noted to be reported more likely as a side effect in the kinase that have the CSK inhibition.
So Talal, one other question would be in their mouse model, what was used to inhibit CSK?
Okay, so I'll go back to this here. So they used a biologic technique, and that is to genetically modify the gene of these mice to be having something, I think, to just simplify it, an on switch and an off switch. So the way that they modified this is alpha M. I'm not really familiar with the naming here, but what it is that this is a gene that is modified to lose its function when tamoxifen is given. So
and I mean, how did they know that? Where did they come up with that in terms of, do you have any idea? I mean,
yes, this is a known technique called Lee cross. So this has been proven on a biological, it's a classical biological technique according to what I've read about it. And this has been used on many fronts, either to gain function or lose function. Go ahead, Arti. Thanks.
Oh, Dan, sorry. This is Arti Asani from BIDMC. I can clarify a little bit. So this is a technique whereby they can perform genetic deletion after the mice have already developed, so you don't have to worry about developmental effects, and it's in a tissue-specific manner. So the CSK expression is abrogated, or actually abolished, during the time when tamoxifen is given, and then CSK can then be re-expressed once tamoxifen is withdrawn. And so it's a temporally controlled and tissue-specific deletion of CSK. So they really relied on genetic manipulation of CSK rather than using a chemical inhibitor, given how those can be non-specific.
Okay, thank you for answering that.
Okay. Yeah, so they, again, let's recap. So they went into the that literature and they tried to find the kinase inhibitors that have been approved that have inhibition of the CSK. And their theory behind that is that they wanted to know in these inhibitors, was atrial fibrillation reported more common? So they found out 51 FDA approved treatments. CSK levels were available in 16 of these kinases. So what they did is that they took these 16 kinase inhibitors and they noted the atrial fibrillation that were reported for these drugs, and then they compared it to the overall 51 reported available data. So this is the graph that they came up with. So they noted that the kinase inhibitors that have a CSK inhibition, or considered to be CSK inhibitors, were more likely to report atrial fibrillation compared to CSK, which had mild or no inhibiting effect on CSK. So that just adds another point to what we just discussed earlier. So to conclude here, to conclude their findings, the long-term administration of ibrutinib was associated with the suppression of CSK. That by itself led to increased inflammation and fibrosis, which predisposes the heart to atrial fibrillation. We conclude from this this publication that the atrial fibrillation is actually a structural remodeling rather than an electrical remodeling of the left atrium. So there is structural changes that induce to the atrial fibrillation rather than a electrical chemical change that is a proarrhythmic effect of ibrutinib. The limitations that they reported is that they found that the phenotype in patients that received ibrutinib were less severe than the patients that did not have that had the CSK function lost totally. And the theory behind that, or that their explanation for that, is that ibrutinib has off-target inhibition or direct inhibition of the SFK family itself through CSK and as a direct inhibition of SFKs. And that can lead to the less fibrosis noted. And the where you can see here that the ibrutinib treated group had showed less fibrosis compared to the loss of CSK function, as well as the histological imaging showing the same thing. So they concluded that this is really a direct effect of ibrutinib on the SFK, leading to its inhibition. Pharmacological agents that were used have off-target effect. Saracatinib also affects SRCs as well. But I think that could be overlooked since they induced a knockout model of the FYN and also did not show an inducibility of atrial fibrillation. The message that I'd like you to take home here is that the atrial fibrillation caused by ibrutinib is really an off-target side effect of ibrutinib. It's not its intended function, and this is just really an off-target effect. Second generation BTK inhibitors that have increased specificity for CSK may avoid this proarrhythmic, and that's really, it's going to be really interesting to see what acalabrutinib has to offer in CLL patients, because I think that would give us a option for patients who have atrial fibrillation induced from Ibrutinib. So that could be our that'd be really interesting to see how that comes out. As well as we should take caution in using medication or kinase inhibitors that have a CSK inhibition, and really monitor them for atrial fibrillation, because CSK is a likely culprit behind the atrial fibrillation, and we need to keep that in mind when we use these kinase inhibitors. Finally, I'd like to thank you, and I'd like to thank Arti for really guiding me through this and helping me understand the lab part and the genetic parts of this talk, and guiding me through this. Thank you all.
Yeah, this is fantastic, Talal, and thanks, Arti, for overseeing this, making sure that we all understand it. I do have a couple of, sort of questions and or observations. So there's a particular case that I have that she was a relatively young lady that was on Ibrutinib for several years and then had an episode of sudden death. She was resuscitated, and at the time of her sudden death, she had LV dysfunction, but that subsequently improved back to normal. And she had a defibrillator placed, and then she was sent to me for what to do now. So they, of course, at that moment, they held the Ibrutinib and wanted to see if she would still need something for her CLL. I think it was CL she was being treated for. And nonetheless, she, about 6 months or 8 months, she was on no therapy, and she did totally fine, and her EF normalized. And then they decided to retreat her with Ibrutinib. And 4 weeks after starting Ibrutinib, she had an ICD shock. And at this moment, I still haven't recovered the ICD interrogation, whether it was AFib or VFib, but nonetheless, she did have an ICD shock. And so my question is, and there has been some case reports about ventricular rhythm disturbances being induced by Ibrutinib. And so, the mouse data that you showed really, for whatever reason, focused the possible injury into the atrium and not so much on the ventricle. But I wonder if it's that specific, and there may be a predilection for the atrium, but there is still some important effect in the ventricle. I don't know if you have any comment about that in terms of the Ibrutinib. And then
go ahead.
The second question would be, how in the world, with all these new drugs that come out, how in the world do you know whether they inhibit BTK or CSK or whatever things they actually inhibit? How do you actually know that?
Thanks, Dan, for the question. First, let me clarify. I probably wasn't clear about that. They looked for both atrial and ventricular arrhythmias, and I think I showed that in my previous slides here. So they did look for both the atrial and ventricular rhythms in all mice, but I mentioned the positive, which is the atrial fibrillation that they noted here. But they did look for atrial and ventricular fibrillation in all the mice that they did the experiments upon. To explain the case that you mentioned, I really don't have a big clinical experience on that, but from reading this article, I would believe that the ventricular LV dysfunction and probably the fibrillation that happened is probably due to the high circulating inflammatory markers, and probably induced the induce deep ventricular fibrillation. I'm not sure, but that's from this reading these articles. This is probably a inflammatory response that happened on Ibrutinib, that when Ibrutinib was removed, she gained that effect subsided. I think that's the answer that I can come up with. Ari, do you have anything to add to that?
Yeah, so I think they really didn't. I agree with you, Dan. The ventricular arrhythmias and sudden cardiac death signal are certainly concerning and could potentially represent a different phenotype or modulation of the same pathway. But certainly this manuscript focused on atrial fibrosis and atrial remodeling and didn't really address the ventricular arrhythmia aspect. So certainly more work is needed in that area. One related point is that in the supplement, they showed that mice treated with ibrutinib developed hypertension, which I thought was interesting because that's another cardiotoxicity that we seem to see in patients increasingly. They found that in fact the CSK knockout did not have hypertension. And so it does beg the question as to whether these different toxicities actually may have different molecular mechanisms. So I think certainly we need models to look at them specifically, both the ventricular arrhythmias as well as potentially the vascular effects of ibrutinib.
Yeah, no, I appreciate the answer. What would you have any comment on, like, so new drugs, you know, second generation acalabrutinib or whichever other TKI inhibitors that were listed on the slide that were CSK inhibitors? How do you know that, or how do you know when a drug comes out whether it inhibits these other things or not?
That's an excellent question, and something that I think the FDA is thinking about. Cell-based models have been used traditionally, but we know that in some cases this is very context specific, and you don't necessarily know as much about the translation to human physiology as well as the translation to whole organ systems. And so there's increasing work being done using induced pluripotent stem cells differentiated into cardiomyocytes that are derived directly from patients. Certainly the Stanford group is doing a lot of work using these as potentially ways to assess inhibition of specific kinases in a human system. It's something that in my lab we're trying to do in a whole organism model using zebrafish, which of course don't develop arrhythmias the same way humans do, but a lot of the kinase inhibition can be recapitulated. And then I think for areas where there are specific agents that we're really concerned about, going up to mouse models and more time-intensive and resource-intensive models is certainly worthwhile, for instance, in the setting of ibrutinib and acalabrutinib, but not really practical for a screening paradigm.
Well, and then I would just be curious about your thoughts on, for example, you know, the whole HER2 receptor inhibition story, you know, that's really played out over 15 or 20 years. We didn't even really know that there were HER2 and HER4 receptors on the myocardium until we saw toxicity, and then we investigated it and find that you know, there are those receptors on the myocardium. And so, of course, in relation to trastuzumab, you could say it's in one sense you could say it's an off-target effect, but really it's an on-target effect because it's the inhibition of the HER2 receptor that the drug was intended to do. It's just that the receptors were on a different organ system. So how this all plays out, like for example, osimertinib, which is a newer therapy for lung cancer. I'm sure you're very familiar with it, but you know, it seems as though there's a spillover between HER1 or ERB1 receptor inhibition, which is what osimertinib is supposed to do, that it may spill over into HER2 or ERB2 because of some off-target inhibition. And so my question again is, with all these new drugs, how in the world do we either anticipate or know when there are these either on target or off target type effects?
I think it's an excellent question and really should be motivating young investigators to go into cardio-oncology, because we really have a need for folks who are comfortable with these various model systems. And I think that for each drug, in some cases, we may need multiple complementary approaches. One interesting thing about osimertinib, slightly off topic from the Ibrutinib paper, is that we do see certainly cardiomyopathy, but we also see some arrhythmic effects like QT prolongation and other arrhythmias that are not commonly seen with HER2 inhibitors such as trastuzumab. And so again, there may be multiple molecular mechanisms involved, and certainly the development of models where we could actually look at those different molecular mechanisms will be useful. There needs to be some sort of screening approach, I think, the same way that we use potentially organoids to look at anti-tumor effects, to side-by-side look at cardiac toxicities. And it raises a great point that we can learn a lot about these molecular pathways in non-cardio-oncology settings. So we know a lot now about the role that HER2 plays in the heart because of trastuzumab. And similarly, now we can look at CSK. So for instance, I wonder if in big GWAS of atrial fibrillation, maybe there is some signal for CSK variants contributing to AFib in non-oncology populations. So that would be something interesting to look at.
That's a great point.
So,
hi, can I ask a question?
I think the easiest way the practical way to approach the answer to both of your questions is that focus on patients that think might be high risk, and that we're not seeing enough of the patients who get started on ibrutinib for sure. And maybe, I mean, that's at least a practical approach to deal with all the new drugs and effects that we don't know about. I also want to mention that you and I were sitting a number of years ago in an ibrutinib session, and I think I said to you, oh, you should look at cardiograms. And we actually did that and published a series where we could predict with an R.8 patients who were likely to develop atrial fib were patients who were not likely to develop atrial fib based on just if there was a left atrial abnormality on the ECG. So that was the sort of you've given us documentation about why that's important, and if patients have pre-existing abnormal atrial conduction or atrial tissue, they're probably also at high risk.
Yeah, great point. Avi, you had a question?
Yes.
There were a couple other, go ahead.
Hi, thank you for the presentation. This was a great presentation. This was very interesting and a topic dear to me. I think we published a series on ventricular arrhythmias, but my question is mainly about the mechanism. And I like that there was a newer pathway which causes atrial structural remodeling, which is highlighted in this paper. Now, there are two other hypotheses, and I just wanted to see if there was any way the authors could connect it to the other hypothesis. One was published earlier this year in the Redox journal, where they connected directly with reactive oxygen species from the CaMKII pathway and how it affects both structural and electrical remodeling. Pretty nice paper in that journal. And then another one, which was the older paradigm, which has been shown in multiple conferences, about the McMullen paper, where the PI3K-AKT pathway, which I believe is probably downstream of SRC, so maybe that is how it's connected. But just wanted to get your opinions on both these connections to SRC.
Talal, did you have any thoughts? I can weigh in otherwise.
And please do.
So in the manuscript, they said
Talal, are you throwing in the towel on that one?
Definitely, Mike. I have a clinical background, so this is unfamiliar territory for me. So Arti, I'm glad you're here.
Well, Talal, you did a fantastic job of walking through those mechanisms. That was really amazing. They mentioned in the discussion that they really did not look in further detail at the connection between CSK and CaMKII kinase, and I think that that would be a lot of molecular work that just didn't quite, that'd be a second paper. Hopefully that paper is in progress by this group. I will have to ask them. But those are excellent points. I do think that those other two manuscripts are probably hitting on something that may be further downstream, and now work is needed to fill in the pathway between potentially CSK and these other mechanisms.
And then, just sort of to going forward, I mean, obviously, a lot of the model was based on mice model, which was confirmed that the protein does exist in human. But, in your experience, how much protein needs to be present, or is there an actual quantification? It was the delta which you saw in that figure, which was presented earlier by Talal, sufficient to make this a reasonable or plausible hypothesis?
So I think rather than the protein levels, what I thought was great that they did was looking at the Cmax, so looking at the plasma concentrations of these drugs versus the IC50s directly in humans. And that to me signifies that if you're giving a drug at a certain dose, that you should be seeing that inhibitory effect at the level of the kinase. So that was certainly reassuring to me. I'm not sure if we can make too much about the tissue expression levels specifically.
Because the reason why I'm asking is, what we were trying to study at some point in time was to see how much of the various kinases are expressed in the human heart. And in the human heart, it seemed like BTK wasn't expressed at all. And obviously that was highlighted here that it's off-target action. So now when it's off-target, what protein is expressed? And it needs to be expressed in sufficient amounts to cause atrial remodeling, because we know that people who do not have pre-existing arrhythmia, atrial fibrillation, tend to develop AFib much later than the people who have atrial fibrillation, which supports this hypothesis directly.
I think it's a great point. In many cases, the expression is inducible, and it may depend on the specific clinical context. There may be patients who have higher baseline expression. There may be other, factors that contribute to the inducibility. So that's why I guess I take those results with a grain of salt, is that I think it probably depends on the context. But certainly, if you think that if there's any argument that it's an on-target effect, you would want to see the protein of interest within the tissue of interest.
Awesome. Thank you so much. These are my questions.
Yeah, it looks like there are a couple other questions out there. I don't know if
Hi, I'll ask my question. Hi, my name is Vicki, and I'm an oncology nurse in Florida. Thank you for this very interesting presentation, but I just wanted to throw out that acalabrutinib is already approved by the FDA. It was approved in November of 2019 for CLL, and in their information, grade 3 atrial fib or flutter only occurred in 1% of patients who were treated with acalabrutinib, 4% any grade in all patients. So it has a much better, cardiac profile as a second generation. And I'm also looking at a marketing piece right now that is showing me the kinase selectivity between acalabrutinib, ibrutinib, and zanubrutinib. So I think if you reach out to any of these pharmaceutical companies where the drugs are coming from, they've got that information because they're looking for something to tease them out from the rest of the group. And that was my comment. Thank you so much.
Thank you.
Yeah, and then Arti, I did want to say appreciated your comment about how this should be motivating to young investigators, and I appreciate that you have that viewpoint. I think that's entirely true, and we need to get some smart young people involved in all of these investigations. So I appreciate that.
Absolutely.
I don't know if we have any other questions out there. If not, I would thank Talal and Arti for such a fantastic presentation. I didn't know about all those details, that's for sure.
Thanks for having us.
Thank you.
Very good. Thank you all. See you next week.
Thank you very much.
Next week's presentation will be on lung cancer and related myocarditis and pneumonitis. So I hope you all can join us then.
Thank you, Steve.
Thank you all very much.